Thank you very much, Dr. Munzer. Dr. Barbara Burton from the United States will be our next speaker, speaking on newborn screening and collapsing the Diagnostic Odyssey for future generations. Dr. Burton is a professor of pediatrics at the Northwestern University Feinberg School of Medicine and clinical practice director in the Division of Genetics, Birth Defects and Metabolism at the Anne and Robert Lurie Children's Hospital of Chicago. Her major clinical research interests are in the area of inborn errors of metabolism and newborn screening. She serves as an investigator in numerous clinical trials of new therapeutics for metabolic disorders, including MPS. Please welcome to the stage Dr. Barbara Burton.
Good evening. Thank you so much for the introduction, and I really would like to thank Terry Klein and the entire MPS Society for inviting me here to give this talk. It's such an honor, really, and I want to congratulate you on putting together such a fantastic meeting. It really is wonderful being here. And I also want to thank Joe Munzer for setting me up so well by emphasizing in his talk how much easier it surely will be to prevent many of the manifestations of the MPS disorders than it is to fix them once they're there. And that's the whole idea behind newborn screening. So I'm really happy that I can talk to you tonight about one of my favorite topics. I'm really passionate about newborn screening, and just tell you a little bit about why I think it's so important for the MPS disorders. But first, I'll show you my city. I'm from Chicago. We're in a beautiful setting here. I mean, the weather, everything, it couldn't be more fantastic. But Chicago is also a pretty nice city, so maybe one year you'll want to meet there. And I work at the hospital up on the top of the slide, the Lurie Children's Hospital, which is part of Northwestern University in downtown Chicago. And you can see our skyline taken from Lake Michigan and the apartment building, you know, second, very next to the one on the right. That's actually where I live. So you're getting a little view into my world here. So let's talk about newborn screening. I think probably quite a few people in the room have had a baby at one time or another. But there's so much going on those first few days after you have a baby that many new mothers, new fathers don't really realize that every baby has a blood test before they leave the hospital for a group of genetic disorders. And that's true in the United States. It's been true since the mid to late 60s. It's true in every developed country, although the disorders that are tested for vary. But all babies get newborn screening. Sometimes it's referred to as the PKU test because PKU was phenylketonuria. It was the genetic condition first included on newborn screening, and newborn screening's been remarkably successful in changing the outlook for patients with PKU who used to have severe cognitive disabilities and psychiatric disturbances, and now can lead very normal lives through early treatment. And more disorders have been added to newborn screening over time. So that in the United States, now most states are screening for at least 30 different conditions. In the U.S., every individual state makes the determination of which disorders will be included in newborn screening, which typically is done in a state health department laboratory. There's some states that have banded together and they do regional screening, but most of the time it's in the state newborn screening laboratory. Other countries, things are going to be a little bit different, and I'm a lot less familiar with what goes on in other nations, but that's certainly true here in the U.S. There is a federal advisory committee that makes recommendations to the state with regard to which disorders are included, and that's called the Secretary's Advisory Committee on Heritable Disorders and Genetic Diseases in Infants and Children. It makes recommendations to the Secretary of the Department of Health and Human Services, who then accepts those recommendations or could reject them. But then that's a recommendation to the state. It's not a mandate. But by and large, most states ultimately fall in line and they wind up doing screening for all of the conditions on what's referred to as the Recommended Uniform Screening Panel, or the RUSP for short. There are 33 disorders currently on the RUSP, and that includes one MPS disorder, MPS 1. 2 other disorders have been recommended by the committee to the secretary and not yet approved, but surely will be. And so there will be 35. There's also an established mechanism for nominating new disorders to be included on that list, which is very important. You can get states to do newborn screening for things that aren't on the list in some cases, but if they're on the list, that's much more of a sure pathway to make sure it becomes widespread. And generally, to consider a disorder for newborn screening, there's some basic criteria that everyone agrees really should be met, and the committee looks at these criteria in considering whether we should add a new disorder. First of all, the disorder should be serious. There must be a test that you can do on that blood sample obtained from the newborn, which is spotted onto filter paper. So it's called a dried blood spot. There must be a test you can do on a dried blood spot to detect the condition, and it has to be a test that performs in an acceptable way. In other words, you're not calling too many healthy, normal babies in for more testing, but yet you're detecting the babies who actually have the condition that you're after. There should be treatment for the condition, generally speaking, and this is an area where sometimes families and decision makers don't always agree, because I hear families sometimes saying, well, there is no treatment right now, but we still see huge benefits to newborn screening, because by the time we got a diagnosis in our first child, we had 2 others who also were affected, and you know, we would have made different reproductive decisions, you know, had we had that information. Or we went through that, you know, looking for a diagnosis for 5 years, going from doctor to doctor. And gee, it would have been nice to have avoided that. But generally, we really want there to be a treatment. And there should be some benefit of starting that treatment early. In other words, if it's good enough just to make the diagnosis clinically, and if you start treatment then, everything's fine, then maybe you don't really need newborn screening. And then finally, there should be some pilot data showing that the screening works. And our committee at the federal level really likes to see some pilot data from the United States. You can look at data from other countries, but they want to see that it really can work in the U.S. setting. So why would this be a good thing for the MPS disorders? Why do we think it is a good thing for MPS 1, and would it be good for all of the others, which I think without a doubt it would be? And one reason certainly is avoidance of that diagnostic odyssey. I know many of my patients, and I'm sure some of you could tell your stories too, had symptoms for a long time before you got a definitive diagnosis. Maybe you or your child had multiple medical problems. You might have seen 3 or 4 different specialists. You knew something was wrong, but nobody really tied it all together until one day it happened. But that can take years, and we know patients not infrequently have symptoms for several years, if not longer, before they get a diagnosis. And by then, oftentimes, they have a lot of disease. You know, there are a lot of issues. And as Dr. Munzer was saying, those don't all necessarily go away if we start enzyme replacement therapy, or regardless of the treatment that we utilize. So we know that there are times when permanent damage can occur, and there can be findings that are irreversible. And we have every reason to believe that preventing development of many of those findings would be much more effective than trying to fix them after they've happened. And then finally, there's the issue of genetic counseling, just enabling families to understand what their risks are so they know what their options are in terms of having future children and can make educated decisions that are appropriate for them and for their children. So I think the MPS disorders meet all of the criteria to be good candidates for newborn screening. We've talked about what those criteria are. Surely these disorders are serious. I think there's no disputing that. Tests are available now for all of them, really, that can be done on that dried blood filter paper sample. We have treatment, fortunately, for many of them, and as you're hearing at this meeting, many more companies and treatments in the works, in clinical trials, or if not yet in clinical trials for things like MPS 3C, at least in preclinical development. So there's a lot of reason to believe that things are going to be so much better as time goes on with these additional therapies developing. And we do have some evidence that starting treatment before you would otherwise make a clinical diagnosis is beneficial. We don't have a huge amount because it's hard to get that evidence. I mean, most of the patients we diagnose on clinical grounds. There are some exceptions. Sometimes we have a sibling born, a baby, and we make the diagnosis because of the family history, and you can look at the outcome in those infants versus the kids treated later, and where that's been looked at in the MPS disorders, we see that that early treatment really is beneficial. Generally speaking, those babies do better than their older siblings who may not have been treated until 3, 4, 5 years of age. So really, you know, in almost every way, really every way, these are great candidates for newborn screening. Pilot data from the state of Missouri formed the basis for the approval of MPS 1 and the addition of MPS 1 to that recommended uniform screening panel. We've gathered pilot data now for MPS 2, and I think it's going to be possible to go to the committee and try to get approval for MPS 2, but we need to move along to try to get some of the other conditions eventually included as well. So we have it for MPS 1, and newborn screening for MPS 1 is now becoming more and more widespread in the U.S. I'll show you a map in a minute that shows you where this is ongoing. But there are several different methods that can be utilized. I don't think we want to talk specifics about methodology, but there's several different ones that work. All of them rely on a measurement of enzyme activity. So when you're doing newborn screening for MPS 1, you're measuring that enzyme level in that dried blood spot. And if it's low, then the baby gets additional testing to find out if the child really has MPS 1. It may be possible in some cases, instead of using enzyme activity, to use GAG levels, quantitate the amount of GAGs in the dried blood spot. And I know Dr. Tamatsu has done work in this area, and he's giving a presentation on this, I believe, tomorrow, certainly on the schedule. So that would be another approach to newborn screening, but all of the programs in the U.S., at least currently, are using enzyme activity. Screening has also been ongoing in Taiwan for a number of years now, and Professor Eto, who's in the room from Japan, was telling me just before the meeting that it's becoming more widespread in Japan as well, although not yet nationwide. So let me just show you a little bit about how it works. This is some of our newborn screening experience for MPS 1 in Illinois, where we began doing this on all babies born in our state in June of 2015. Thus far, we've screened close to 600,000 infants, and we've had about 355 positive tests come back. That means the baby needs further testing. At that point, they're seen by a consultant, a geneticist typically. They get enzyme measured on a whole blood sample, so it's on white blood cells. They get urine gags, and if the enzyme's low, we also do molecular testing to look for mutations. And you can see that in those 600,000 cases, we've identified only 2 patients with MPS 1. They both had the severe Hurler form of the disease, although they had very few clinical findings at the time of evaluation. Both of those babies had the benefit of undergoing stem cell transplant, bone marrow transplantation, before 3 months of age. So we think their outcome is going to be fantastic. We know that the earlier transplants done in MPS 1, the better the patient, the better the outcome is in the patient. I'm following one of those kids who now is 3 years old. She's doing beautifully. She is just spectacular. And another one is being followed in St. Louis. The thing, though, that I want to point out is the second line on the slide, and that is we've had 110 patients detected with what we call pseudodeficiency. And this was a little bit of a surprise when we started MPS 1 newborn screening. Fortunately, Missouri had started before Illinois, so we learned from their experience. But pseudodeficiency is very common in our African American population. And what that term pseudodeficiency means is that if you measure their enzyme activity in the test tube, it looks like they have MPS 1. It's very low. You know, you can't necessarily distinguish the level of enzyme activity from what you'd see in a patient with MPS 1, but their urine gags are normal. They do not accumulate gags. They do not develop disease. So they have alterations in their iduronidase gene that cause it to function differently, presumably gives them enough enzyme activity in the body that they don't have disease, but what we measure in the test tube looks deficient. So recognition of the existence of pseudodeficiency is very important, because when we're looking at a patient who looks like they have an MPS disorder, we do the enzyme test and it's very low, we think, okay, they have it. But in a baby with newborn screening, we're not looking at somebody where we can tell if they have an MPS disorder or not. We're looking at a normal baby. And so we have to be very careful not to falsely identify that child as having MPS 1, when really what they have is pseudodeficiency. They don't need treatment. They don't need follow-up. They're going to be fine. And fortunately, the specific changes in the gene that cause pseudodeficiency for MPS 1 have been identified now, or at least several very common ones that we find in most of our African American infants who have pseudodeficiency. We occasionally see a baby from another ethnic group who also has pseudodeficiency, but fortunately we again have the urine gags to help us differentiate. We also get a fair number of false positives where once we do the enzyme on the whole blood sample, you know, we see it's normal, and, you know, then again, we don't have to do any further testing at that point. And that's true with any screening test. You're going to have some false positives because, you know, it's not as quantitative, it's not as clean a test as what you would do on a whole blood sample. Sometimes the quality of the spot, you know, is not that good, or there are other reasons why the enzyme activity might be low. So that's MPS 1. Now, one of the states who is doing MPS 1 screening, that's the state of Kentucky, uses Mayo Labs to do all of their babies, and they're using what's called second-tier testing, which means they start by measuring the enzyme like we do, but instead of saying everybody with a low enzyme has to go to the consultant and get these follow-up tests, they do a second test in the newborn screening lab, which is to measure those gags in the dried blood spot. And if those are normal, then they just conclude this is normal or pseudodeficiency. They call it normal. They only call it abnormal if the enzyme is low and the gags are elevated. And doing that has led to, a much greater degree of precision in identifying the patients at risk. They screened a little over 130,000 infants and only reported out 2 positive screens. Remember, we had 355 out of 600,000, so a lot more. One of those turned out to be a baby with the Hurler syndrome, and one was a carrier. So this is a really good way to go, I think, if a state lab can do it. I mean, not all state labs may be able to do it, but they may be able to contract, with other facilities, Mayo or others, to really tighten up the newborn screening process. But it works the other way. This map was current as of about March of this year. I think there have been a few changes since then, but it shows you which states are actively doing MPS 1 newborn screening. It also includes Pompe, which is the other lysosomal storage disorder on the panel. The states colored in green are all doing both Pompe and MPS 1 on all newborns, so really a lot of the middle part of the country, the Midwestern states like Illinois, Missouri, Minnesota, Wisconsin is now on board, Michigan, Pennsylvania, Ohio, Kentucky, Tennessee, New York. If they're not completely statewide with MPS 1, they will be very shortly. I think they may already be there. California, by the end of this year, will be bringing MPS 1 and Pompe on board. So the ones in pink are slated to begin by the end of this year. So it's moving along really nicely, I think, from state to state. Obviously, there are things that have to go on the state level to gear up, to figure out how to finance it and, get the testing in place and so forth. But I think it's moving along pretty well. MPS 2 newborn screening is currently ongoing in Taiwan. As I mentioned, it's being multiplexed there with several of the other MPS disorders. In the U.S., the only state currently doing newborn screening for MPS 2 on a prospective basis is our state of Illinois, although Missouri is scheduled to begin in 2019. And I'll show you just our early experience with this. We just started this past December. So this is data from about 6 months, a little over 6 months, screening 93,000 infants. This is a lot tighter than the MPS 1. We have a lot fewer referrals for further testing. There were only 9 positive screens out of those 93,000 infants. They were all male. And one of those turned out to have confirmed MPS 2. 2 were normal. 2 presumably have pseudodeficiency like we see with the MPS 1, but with MPS 2, we don't really have the information yet about specific mutations that are linked to pseudodeficiency, but we do have several infants where they have deficient enzyme activity in whole blood. They have normal urine GAGs. They do have a variant or a mutation in the I2S gene, and we think that variant is spelling out pseudodeficiency. In one of the families, we tested other family members, and we found the same mutation in the maternal grandfather, who was a man in his 50s, and he's perfectly normal, so we feel pretty confident this is just not MPS 2 that's going to develop later on. And we have a few, all of whom have normal GAGs, where we're still waiting for the molecular and final confirmation. So like MPS 1, we're going to see some pseudodeficiency. It's been reported in Taiwan. They have pseudodeficiency there. It isn't as common as it is for MPS 1. And we don't know if it's restricted to certain ethnic groups or more common in certain ethnic groups, but we will see it. We will have it. So, but the screening works beautifully, I think. It works very well. This baby that we detected is on enzyme replacement therapy and has been since about a month of age, 6 weeks or so of age. So what about the other MPS disorders? Well, we know that in Taiwan, they're doing testing for MPS 4A and MPS 6. So we'll have some nice pilot data emerging there. Dr. Giuliani in Brazil has been doing MPS 6 newborn screening in a particular region of Brazil that has a very high incidence of MPS 6. I'm not aware of any ongoing as yet for MPS 3 or MPS 7, but I know it can't. Oh, we have Mike Gelb raising his hand, so he must be aware of some. Okay, MPS 3B in Taiwan, and they all can be done. He's the guy that developed the testing techniques, the technology that enables all of this testing. So he should know, and I think he's given a talk later in the program as well on a topic related to newborn screening, so you'll get a chance to hear more from him as well. So what can families do to promote newborn screening? If you believe, like I do, that this is really in the best interest of your kids, your grandkids, our kids overall, I mean, all of our kids, then you can do something to keep it moving. If your state is not yet in the process of implementing newborn screening for MPS 1, which is on the RUSP, go home and find out why not. Find out how in your state new disorders are added to the screening panel. Sometimes it can be just an administrative decision made by the health department with advice from almost every state. I think every state has a newborn screening advisory committee. But most of the time it requires legislation to add new conditions. Or even if it doesn't require it, for example, in Illinois, it's not required. Our health department can decide on their own to add new conditions, but they don't. So it moves a lot faster with legislation. If you find out a disorder is being discussed at a newborn screening advisory committee, these are all open meetings virtually everywhere. These state-sponsored meetings, usually open. Go to the meeting and speak up. And if legislation is needed because it's required in your state or you want to get action more quickly, go to your legislator and get them involved. There's nobody who has more power than the constituent, the patient, the parent. In the state of Illinois, we were the first state in the nation to have legislation passed mandating lysosomal storage disease newborn screening. Took a long time to get it implemented, but that legislation was passed in 2007. And it was passed because there was one parent, a father of a child with a lysosomal storage disorder. It happened to be MLD, not an MPS disorder. But he wanted screening for his condition. He found out it wasn't ready for prime time. It couldn't happen, but he realized in the course of his research that there were all these other patients out there with other conditions who really could be helped by newborn screening. And 6 months later, we had a law that mandated the addition of 5 of those disorders to our newborn screening panel. He came and went back 3 years later when they still hadn't done it and negotiated and gave them a little more time, but added MPS 1 and MPS 2. That's why we're doing MPS 2 newborn screening. So you are powerful. And I think you've seen it through a lot of your advocacy efforts, but you certainly can translate it into the newborn screening arena also. So with that, let me just thank you again for this fantastic opportunity to be here with you and wish you a very wonderful meeting. I think it's going to be a fantastic few days. Thank you. And we have a minute or two, so if anybody has any questions. Okay, we have one, it looks like.
Okay, so I know one of the requirements to get the newborn screening you mentioned was that there are no false results, right?
Well, you can have false positive results. It just has to be an acceptable level. I mean, you can't have a test that, where everybody comes out positive. I mean, it has to be acceptable test performance. But there's always going to be false positive results.
Okay, and you said they test first the blood to see the enzyme level, and then if they suspect the child has a disease, then they test the GAG levels. Since they accumulate, throughout time, is there a possibility that they can test the GAG and the enzyme, and it seems like the child doesn't have the disease, but indeed they do?
Well, that actually is a fantastic question. I mean, that is a little bit of a haunting concern. I mean, all of the patients that have been detected in the states doing it thus far have had very elevated GAG levels, and we now have more precise tests for measuring those urine GAGs than we used to. But the question is still out there. Could you have a patient who has a very attenuated, or a milder form of one of these disorders? They have low enzyme activity, but at a week or 2 weeks of age, their urine GAGs are not yet elevated. We can't say that that's absolutely impossible, because there are relatively few patients like that where we have those urine specimens from that early age, or even have blood spots from those early ages. I think the prevailing thought is that that's not very likely, that we should be able to distinguish them, particularly now that we have these quantitative measurements that allow you to see each of the individual GAGs. We can see if the heparin sulfate's elevated, the dermatan, et cetera. We're not relying on a total GAG assay where we know in the past there have been false positives in the babies. But, it is something where we think the answer is no, but we don't really have a huge body of evidence to say that with certainty.
Well, thank you, and thank you for what you're doing, because it's really important and it means a lot to us, because I wish my son would have been diagnosed sooner. So
Absolutely.
I appreciate it, and I'm going to do my part in at least helping in Florida to get that approved. Thank you.
That's great. Thanks. All right. One more.
I'd just like to reiterate how important it is to, for a lot of people looking at it, they say, well, maybe it's too late. But for people who have families and are having a kid every other couple years, by the time your son's diagnosed at 3 years old, it's too late. So
Yeah.
I appreciate what you're doing and the importance of that. My question would be, if we're going to go to our home states and kind of fight for this, is it super expensive? Why are they not doing the testing?
There is a cost associated with it. It's going to vary from state to state. That's the kind of thing where you get with either your legislator or call whoever's in charge of the newborn screening lab or the genetics program in your state. Find out how it's funded. For example, in my state of Illinois, there's not 1 penny of taxpayer money that goes into newborn screening. Nothing comes from the General Revenue Fund. There is a fee charged to each baby for the newborn screening test. When they add new disorders, they add a little bit more to the fee. It's now something like $110 per baby. That's an incredible bargain, for 35 conditions. And typically it's paid for by health insurance or Medicaid or the payers. That money in our state goes into a separate fund, and the proceeds from that fund are used to pay for the laboratory and the calls to the doctors, all of the follow-up and so forth. In other states, it comes from a legislative appropriation. So yes, money is often the hang-up. That's often the delay. Sometimes it's just bureaucratic delay. Sometimes you may have to convince people on your state newborn screening advisory committee that it's a good idea. Sometimes the people on the committee aren't that familiar with MPS disorders. On our committee, for example, we have about 20 people on the committee. Only 2 or 3 are geneticists. There's endocrinologists and general pediatricians, and so they need education, and who better to give them that education, than you guys, when you find out when those meetings are going on. So sometimes it's that, but money is probably one of the biggest factors, yes.
Thank you very much.
Thank you. All right, Professor
Okay, thank you
Ada.
very much. Nice talk. And I would like to ask you about the newborn screening of Fabry disease. In Japan and Taiwan are doing a newborn screening for Fabry disease, but there are some augmentation because of the late onset type. But if you find out the patient, a newborn with Fabry disease, maybe you can treat their family as soon as possible. So what in your state, also you are doing the newborn screening of Fabry disease, but there are some opinion against this kind of the
Yes.
concept.
Yeah, I mean, we are doing newborn screening for a condition called Fabry disease, which is another newborn screening disorder, but one where patients very often remain asymptomatic for very long periods of time. So we diagnose a lot of babies with Fabry disease, and virtually none of them get treatment because they're all asymptomatic, and many of the mutations we find are ones that are predicted to be late onset, where they're not predicted to have symptoms in childhood at all, but it causes kidney disease, heart disease, other problems in adult life. We do screen the parents, the mothers, and grandparents, cousins, and so forth. And there have been a few examples where someone else in the family has appeared to have symptomatic Fabry disease and gotten started on treatment because of the identification of the baby. But I think the reason it's more controversial, I mean, I don't think it's anything like this. Fabry disease is more controversial because we don't really know for sure when you need to start treatment. And you know yourself, we go to these meetings and some people get up and say, oh, if you have a male, you should start by 10 years of age. And other people say, well, no, you can't do that if they might not have symptoms till 20 or 30. If it were an inexpensive pill, yeah, we'd be treating all of them. But it isn't. It's an IV infusion. It's expensive. So I think there are a lot more unknowns, unanswered questions with Fabry disease. But we are doing it. They're doing it in Missouri. But it's not really quite, the case for it isn't as clean as it is for the MPS disorders.
Okay, thank you.
Yeah. All right, thank you so much.
Thank you very much, Dr. Burton, and thank you to all of our speakers, not just for your presentations, but for the important work that you do. Our next speaker is Dr. Jama Nateqi from Austria. Impressive young man. Dr. Nateqi founded his first successful business in 1999 at the age of 16 years old. He then self-financed his studies of human medicine in Austria and performed research at Yale School of Medicine. Dr. Nateqi is a medical doctor and co-founder of Symptoma.com. This is a search engine for diseases that empowers physicians to diagnose even extremely rare diseases. Please welcome me in joining Dr. Nateqi to the stage.
Thanks for having me. So, my name is Jama. I'm a medical doctor and co-founder of Symptoma. And Symptoma is a search engine for diseases. Now, to illustrate the problem that we are addressing with Symptoma, I would like to introduce you to Isaac. And Isaac was a charming little boy at the age of 3. And someday he just started grunting for no reason at his peers and friends in kindergarten. At first, his parents didn't mind it and thought it's just part of the normal child development. But then Isaac also started screaming for hours as if in severe pain. When he wasn't screaming, he just stared vacantly into space. Isaac became depressive and suicidal at the age of 5. Terrifying thoughts of death plagued him. Whenever the word death came into his head, he would smash his head into windows and walls in order to drown out his thoughts. He couldn't go to the bathroom alone anymore because of the voices he heard in his head and the things he saw. Fears became immense and paralyzing. Over a course of 4 years, 100 doctor visits, and a host of misdiagnoses and mistreatments, his parents tried to make peace with the idea that their son might never come back again. 1 in 7 diagnoses are misdiagnoses. Each year, 1.5 million lives could be saved with the right diagnosis. But what causes misdiagnosis? It's misinformation. Physicians have to consider more than 20,000 diseases at once, and this is more than they can handle. So what can we do about it? The medical knowledge has already been published, but it's really hard to retrieve the right information in a timely manner. And there are already great approaches out there. So companies have tried since the 1970s to establish so-called symptom checkers. However, their databases are far too small in order to provide any sufficient accuracy. We have developed Symptoma, a search engine for diseases. So users enter symptoms, age, and sex, and they receive a list of matching causes sorted by probability. And this is actually high technology. We have invested 11 years in research and development and so far established the biggest disease database in the world with 20,000 conditions and millions of connections to symptoms, risk factors, and statistics. We have therefore processed millions of medical articles and publications in order to come up with a database. We are already the dominant player in the industry, reaching 1 million monthly active users, and next is webmd.com to tackle regarding their reach. We are headquartered in Austria, lake-sided near the Red Bull headquarter, and we have a branch office in Salzburg. Overall, there are only 150,000 people surrounding our companies, our offices. However, we managed to attract quite a lot of people also from outside. So currently we have 15 employees in Austria, mostly engineers, and 45 medical doctors from all over the world. Tom and I have been working together as co-founders since 2002. And this is our second joint business. Our first social enterprise was in the educational market. And since 1999, all of our websites have reached 500 million visitors. And we've grown our first team to a team size of 100. Symptoma has won some acclaim. So the European Commission and the Dutch Ministry of Health has said that we are the best and most promising ES solution in 2016. Even the German Minister of Health said, okay, Symptoma is one of the best 10 healthcare innovations in the world. And therefore you have to know Austria and Germany are always, there are always some tensions. So for a German minister to say that an Austrian company is good, it's actually something that's unique. And also most recently, we have been invited to speak in the European Parliament as one of the best 50 companies in the Union. And the European Commission has also awarded us several million US dollars in order to advance our research. So how can Symptoma help Isaac? By luck and chance alone, his parents came across a crucial piece of information, that his symptoms actually match a disease called PANDAS. And PANDAS is a rare autoimmune disorder. The treatment? A simple antibiotic. The results? Dramatic. Within the next day, his hallucinations just went away. And within a couple of weeks, all his symptoms just faded away. And this was just due to a simple piece of information leading the way to his cure. And he smiled again for the first time in nearly 4 years. Now, Isaac is yet one of the lucky ones, because when it comes to rare diseases, 3 out of 4 patients don't have the diagnosis yet. 10% of the population is affected by a rare disease, and those who were lucky enough to actually get the diagnosis, it took them an average 10 years from symptom to diagnosis. So here are a couple of some examples of patients. So this is a little girl at the age of 2, and you would search, and she's suffering from recurrent multiple infections. So you say, okay, she's 2 years old, and then you state the sex. And by the way, we are the first and only solution in this space to actually also have the option of saying, okay, this is an intersexual patient. There are 1 million patients worldwide affected by that. But she is female. And then you enter further symptoms, such as she has middle ear infections quite often. She has a short neck, a prominent forehead, facial dysmorphism, and maybe you have seen it, MPS was always within the top 10. And it actually was MPS 2. And then you can even go further. because there we have a chatbot asking for further symptoms in order to narrow down and saying, okay, it's really MPS 2. Of course, technically, only the physician is going to make the diagnosis, but this is really helping. So here we would ask, okay, does the patient often has diarrhea? Yes. How about mental retardation? Yes, a little bit, a mild one. Is the liver enlarged? Yes. Is there a seizure? No. Is the tongue enlarged? And you always see definitions on what we mean with the symptom, and also pictures or photos that might help to answer. And there is a battery of questions, and at the end is that we say, okay, we are sending you a report with a summary and with the most likely diseases. And in this case, you see what are the symptoms that you have that you have stated, and the others that you have neglected. And then you again see that MPS 2 could be confirmed based on the database. However, of course, then the diagnostic kit is helpful, and some of our customers are actually providing those kits to their doctors because, for instance, in Germany and Austria, patients are not fortunate to have the newborn screening yet. Good. The same patient, and now the parents are searching, and they're searching using different words, of course. Physicians and patients obviously use different words, and so the little girl also has stubby fingers, which are short, so short fingers as well. She has an abdominal distension and a wide, flat nose. Again, MPS 2, one of the top results. The same patient, another journey. So she also has stiff joints, and she has an umbilical hernia, and her liver is enlarged, and spleen as well. And again, MPS in the top 10. And also here the chatbot can help and ask, okay, does the patient has a jaundice? Yes. Fever? Yes, quite often. Enlarged gallbladder? No. And again, this is going to help to actually navigate the diagnostic journey. Another patient, also MPS, just a couple of symptoms, 5 years old, a little boy, short stature, the bones are deformed, a round back, and again, you can see MPS, in this case, also in the top 10. Another boy, back pain, scoliosis, and visual impairment. And this time it's mucolipidosis. Another boy, a delayed development, recurrent middle ear infections, a large tongue, microcephaly, and this time it's alpha-mannosidosis. And it also works not only for rare diseases, but also for common diseases, such as this woman which, having fever, productive cough, prevalent sputum, and it's acute bronchitis. Another girl, she has itchy and red eyes, and excessive tearing and sneezing, mostly in the spring. Okay, what could it be? It's an allergic condition, allergic rhinitis. Another patient with history of asthma, wheezing, decreased oxygen saturation, and further symptoms, and this time it's an anaphylaxis, a severe allergic reaction actually. It also works for basketball players, so if someone is here playing basketball. A knee pain, one of the most common conditions is actually the torn meniscus. And I hope you didn't have that at any time in your life. So undercooked eggs, if you have experience with that, diarrhea, abdominal pain, fever, nausea, salmonella infection. You don't want to have it. Good. So in a nutshell, as I said, the biggest disease database in the world, and it's there in order to help patients decrease their long journey in order to get the right diagnosis and the right treatment. And this is what we are fighting for since 11 years. And I'm going to stay available both tonight and tomorrow and on Saturday. If you see me, you can just grab me. I have my laptop here, and we can just perform the searches also on new cases in order to check that if someone else is searching with a similar case as yours, that they might actually get the diagnosis as well earlier. Thank you. I'm also open to questions. I'm sorry? No, it's really just like Google. You can go to symptoma.com and start typing for free. So it's for free for doctors and patients. Oh, actually, we were not the first one having the idea. There are so many approaches since the 1970s that actually tried it. The key was not actually having the idea, but the perseverance to actually go for it. And I think our European mentality or culture helped here, because for us, failure is not an option. It literally would have been an embarrassment giving up your career, pursuing something like this, and then it's not working. As opposed to the US mentality, which is quite strong in other startup or tech scenes, where the mentality is failing fast. So there have been a lot of approaches in the US that didn't really pan out, and we were able to actually out-compete big corporates such as IBM Watson. And at the time when we started out, there have been big reports on 20 pages from a university professor stating that it's impossible to do something like that, and that we guys especially wouldn't be capable of doing so. So I think really it was perseverance. Yeah.
Jama, I want to say a big thank you for turning up here. I really absolutely wanted you to speak here because I'm so impressed by the work you're doing, and I think everybody should know this all over the world. And you need to speak at other big conferences too. This is so impressive and so important. Thank you.
Thank you so much, Michael. Okay, thanks. As I said, I'm going to be available both right now and tomorrow. So if you see me and want to just recheck it, just grab me and we will have a short session. Okay, thank you. Take care.
Again, many thanks to our incredible speakers today. I'd just like to inform everybody that dinner will be served on the Bayview lawn. The reception begins fairly soon, I believe right at 7 p.m., and then we'll start here bright and early again tomorrow. Thank you all very much. Enjoy the reception.